How's everybody doing on this beautiful Saturday? I'm getting some echo. I don't know if that's just me. If you guys are getting echo, can you give me echo on there and I'll do a little audio fix. If it's just on my end, I'll deal with it. Let me get this up as well on my phone. I'm going to give some folks some time to get here. Let's see. Give some people a little bit of time, but I want to get it up on my phone so I can see who is talking. And if you can look at the little let your name be seen by eCam on the post, that way I can see your name when you comment. Otherwise, you're just anonymous. Maybe you want to remain anonymous and you want to say nasty things to me. I'm just kidding. But if you don't mind, that would be great if you guys could do that. Let me just get this up. Samad PT, always good to see you, my friend, all the way from Nepal, I believe. I appreciate you tuning in. John DeLucci, good to see you. Yes, my post about test retest and what we're going to talk about today was inspired by this gentleman from, I believe, South Carolina, North Carolina. Recent new dad. Good to see you, buddy. Daughter must be sleeping. All right. So, without too much time, I want to respect you guys' time on a Saturday afternoon, but I wanted to come on and talk a little bit about test retest. I just think it's a topic that is one I was reared in very heavily in manual therapy, that and still feel it's an important process to know, understand, and utilize appropriately. The key thing being utilized appropriately. And as I've learned about pain science and some different ways that pain can be affected, and truly how easy it is to make a within session change with some pain by a variety of different methods, that I think it's important that we kind of think about test retest and maybe kind of put it in its perspective of what's in the best interest of our patient meeting their valued goals, not our system, not our beliefs, not our biased treatments, more how do we make it patient centered. So with that said, let me just get into, so it is an important tool in clinical reasoning. I mean, you can't just, and I'll admit early in my career, I did the old mud on the wall approach where it was like, I'll throw 13 different manual techniques at you. Oh man, you're better at the end of the session. Awesome. No idea which technique was effective, which one they liked, which one they felt was helpful. I was just, throwing them out at the wall, seeing what sticks. Same with exercise. Obviously, there wasn't just manual therapy. It was all just a mix of things, and really had no clue what was doing what and what was really generating change with patient. So I really didn't have any way to kind of zero in on what techniques were gaining the best response from patients. We know that response is much more than just the mechanics of the technique under your fingers or how well you execute it. It's how confident you are with it, how well you explain it, your non-specifics around it. There's a lot of different things, but regardless, it is a good tool in clinical reasoning to see, is your treatment having an effect? And we're going to talk a little bit about, well, is it realistic for somebody in persistent pain to really expect that you're going to make a within session change? Although, let's be real here, it's not hard to do some relaxation based things, some massage, even some nice gentle manual therapy mobilizations, and make somebody feel better. Our massage therapy colleagues do it as a career and do a wonderful job of modulating somebody's muscle tension, pain, and different things down. They're very skilled at it. They can produce pain modulation probably better than most with soft tissue techniques. But it's not the only option. That's their desired option, and that's their trained option. That's great. Mine has been more manual therapy and moving more towards the exercise and less of manual therapy over the years. But we just have to recognize that it's not, doesn't signify that our technique is special, that it's something that is amazingly, that it's the only way that somebody can gain within session change. Now, granted, we're going to have definitive biases and trainings in our careers that are going to make us most likely to be able to create change with our desired technique because we are confident in it. We provide a context with our desired technique. Maybe our desired technique fits the culture, either the area of the country we're living in, maybe the area of the world we're living in, where this treatment may not work well in a different culture, but because that culture ascribes meaning and value to that treatment, man, there's a lot of better outcomes in that culture. And that's okay as long as you understand it. And in the end, it shouldn't be about our treatments. It should be about us handing the reins to patients about about their condition, giving them the reins to be able to pursue the valued activities that are important in their life. So it's definitely something I would recommend we continue doing, but just recognize its limitations. It's not something that um, is is getting a change in a test retest is just a sliver of what's important in the long term of the patient. Now, we'll talk here in a bit about how do we make that become a meaningful change that the patient has. And like I said, there's many options to do it. We just kind of talked about it. But um, going to, I mean, you got people who are all fans of needling now. There's still the manual therapy folks. There's the folks who are very big in soft tissue, our massage therapy colleagues and others. Um, all of these folks, I guarantee you, aren't lying that they're getting good outcomes, that their patients are showing change and improving. It's just, I think if we understand we're all doing the same thing, just under different, modes of delivering a change, and a change that hopefully lines up with best that patient's beliefs and expectations is probably gonna be the best one, or the one that you're better able to portray as the one that's going to help the patient based on your confidence level, your biases, and all these different things. It's okay to have those. Just be real with yourself and understand that that's part of the gig. Kevin DeGroot, Jared Hall, good to see you. Mr. Beloy, always good to have you here as well. Um, so yeah, I just think we have to be careful when we try to make our techniques be the centerpiece of our treatments. But the other big thing is, well, who owns the change? Like when you make a change with a patient, how does that patient view it? Do they view it like, oh my God, Mark's magical hands just amazingly, manipulated. He cavitated, 6 joints. Not that most patients don't give a rip about cavitations nor know what it means, but they give a rip about them, but they don't know what that word means, of course. But again, who owns it? And I think you just got to be careful. And that's where I've really pumped my brakes on being dead set that I have to be the one to deliver the change with my hands. Now, there are some times I think that, based on patients' expectations, beliefs, and them not showing the signs that they may be one who's going to be dependent upon my hands, I might nudge in there to show them that there's change possible. But if the patient sees that as you owning that change, and they don't leave their clinic with any option to maintain that change or produce that change on their own, then are we truly helping those folks in the long run? I would argue that we could probably do a little bit better. I know this is just speaking from my experience in my career. I owned a lot of patients' changes, and I was proud. I was pumped, man. If I could manipulate and look at how much fingertips to floor now, he could barely touch his knees. Oh my God, I'm amazing. Um, and but again, the more and more I've practiced, the more I realize that's not all that exciting. You can do it for many ways. I've also been trained with McKenzie stuff. Amazing ways you can make within session change with repetitive movements. Again, one option, not the only option, and sometimes maybe the best option based on the patient's presentation and their beliefs and expectations and different things. But again, we need to make sure that when we're using test retest, and we're using it with a passive technique, that we somehow can portray it. So what would I do? I'd say, well, we just nudged on this joint and gave it some, repetitive movement to see if we could kind of get that sensitivity of those nerves and those tissues to start calming down as we nudge in there. Your system showed some amazing stuff with that technique. Look at it. You're able to move better. You're less sensitive to, and I got less sensitive as I was touching and mobilizing you here. So that was a great response. And the key is I don't want this response to only last a temporary time period. Manipulations, we know the time frame, 2 to 3 hours or so of significant effect, depending on what you read and some of the literature around our neurophysiologic effects and how long they last. But the patient needs to understand that it's temporary and that it's something that they need to maintain and move. And Matt Lowe, and I'll probably butcher his quote, but he said, this is just a technique to prepare you for the treatment that's truly important. And that's you moving well in valued activities that bring you satisfaction and joy in your life. I thought that was a beautiful kind of semi-quote. Again, I didn't say it exactly as Matt, that he says things more eloquently than I do, but I think that's just a good way to kind of look at within session change with folks. The other thing, and Jared had mentioned this to me as I was talking with him about these posts, we always kind of bounce ideas off each other and discuss it, and I will fully say this was me a good chunk of my career. It is easy to get stuck being content within session change or a change on a test retest. You can park yourself in a treatment for a good period of time, and those are the patients that end up being your 15, 20, 30 visits on your schedule. Oh my God, they're still coming back. And to me, and I've been guilty of that, so I'm not by any means claiming innocence with any of that stuff. Zach Huff, Dave Robbins, Christopher Boyette. Good to see you guys. Um, so yeah, I think we have to recognize, is that change translating to something? Is that change translating to the patient not needing you to do it again? If it's not, then there's something probably missing in the puzzle. And oftentimes it's maybe the patient's mindset. I would be asking them, you know, what are your thoughts on being able to change this pain like we did today? Do you feel like you have strategies to do that in your with your home program that we did? Or maybe it's time to utilize some active repetitive motions or some exercise based modulatory techniques or tweaking biomechanics or doing some other form of symptom modulation that does not require you as the therapist to be there delivering it, and show them and put them in a situation, a behavioral experiment where they do their own test retest, they do their own self treatment, and you show them that, oh, look at what just happened there. You just changed your pain with this movement. I think that's a powerful experience for most patients to undergo, so they can see that, man, this thing, I can get some control over it. I have some abilities to modulate these symptoms on my own. So powerful stuff if you can set up those clinical scenarios to do it. Um, I've really, in my career, moved away from this magical belief that manual therapy is something special and amazing. It's something special and amazing if that's the way you portray yourself to the patient world, that's the only way or the best way you feel is to um, deliver change. I don't think it's the only way to deliver change. It is one of the main ways I deliver change, but it's very much de-emphasized and sat back to the backseat, I guess you would say, and not got so driven by it that it was. I mean, I was chasing alphabet letters and fellowships and different things, and thought that was the answer to patient care. And I just happened to get a good pain science course in my fellowship that really turned my career around, because I was going to be stuck at the latest manual therapy conference, whacking and cracking techniques for the rest of my life if I wouldn't have gotten out of that mindset. Because it's very easy to get stuck producing within session changes with a whole group of people who are excited about producing within session changes with their desired technique or their biased technique. So hence why you should always question things. You should never get tribal with treating only the way somebody else tells you should treat. Why don't we treat the way our patients feel like would be the best way to help them get towards their goals? So I'm going to leave you guys with probably my favorite quote of this pioneer, this gentleman over, he's blocked, right over here. Lewis Gifford, you guys know him. If you don't, you need to read his stuff. His Aches and Pains books are worth their weight in gold, just because they're such awesome abilities to see his reasoning and thinking process and how he was doing this stuff and thinking about this stuff so long ago. But this is something I think we should hang on our desks and say, am I being this therapist? Am I a therapist who, if this therapist only does the treatment to you and misses out on the get it moving, rehab, graded recovery, functional recovery process, that's, in my opinion, that your therapist is a complete waste of time. And I was definitively a complete waste of time for my patients, for some, earlier in my career before I understood all this stuff. I was just excited that I could make their pain change in front of me. They were happy. I was happy and came back the same way, but I didn't know any the wiser. I was just convinced that the answer was in their tissues and I needed to find some new way to nudge and crack or mobilize or manipulate or whatever it may be. So I challenge you guys to not become that therapist. I challenge myself every day to not become that therapist who's a waste of time for their patients. Are we really, truly moving patients towards their value goals, towards things that are important to them, to treatments that they value, not that we demand? Are we fitting us to them or are fitting them to us? I definitely fit them to me earlier in my career. Now I'm much better at trying to fit myself into their world and find some constructive ways to move forward. So yeah, that's just a little bit of my perspective on it. We're going to be talking in depth when we get into this guy up here, in November. So if you guys get a second, check out the Complete Patient Experience page on Facebook. We got an awesome event in November. I'd love to see you guys there. Also, Jared Hall and myself are in the process of finishing up a membership program that's going to be ability for people all over the world to get regular content. We're going to be, keep your ears out on this Facebook group, because I'm excited. It's going to be some amazing therapists and amazing experts from all over the world, some amazing content you're going to get dumped to you every month. I get excited just talking about it, because it's where I think I'm feeding my passion, and it's going to give us the ability to help a lot more people than just groups of small classes. So hope you guys have a wonderful rest of your Saturday. Thanks for tuning in, and hope to see you guys soon.